Welcome, everyone, to this virtual conversation focused on mental health challenges in the veterans population and the science underlying them. I'm Dr. Carrie Wolinetz, the Deputy Director for Health and Life Sciences at the White House Office of Science and Technology Policy, and I'm incredibly fortunate to be joined here today by two preeminent science and health leaders from the United States Department of Veterans Affairs. I'd like to start by introducing Dr. Wendy Tenhula, who is the VA's Deputy Chief Research and Development Officer. Welcome, Wendy. Dr. Tenhula has been at the VA for over 22 years and is trained as a clinical psychologist. The Office of Research and Development aims to improve the lives of veterans and all Americans through healthcare discovery and innovation. VA research is unique because of its particular focus on health issues that affect veterans, including what we are here today to discuss: mental health conditions.
Hi, Carrie. Thank you.
Thank you for joining us today, Dr. Tenhula. I am also fortunate to be joined by Dr. Tamara Campbell, who is the Acting Executive Director at the VA's Office of Mental Health and Suicide Prevention. Dr. Campbell is a United States Air Force veteran. Thank you for your service, and a practicing psychiatrist. The Office of Mental Health and Suicide Prevention is responsible for monitoring and supporting the implementation of mental health and suicide prevention policies and the performance of mental health programs in Veterans Health Administration facilities. Welcome, Dr. Campbell. We are gathered here today for this conversation in support of President Biden's Unity Agenda, two pillars of which we'll touch on today, including first, tackling the nation's current mental health crisis, as well as supporting our veterans. On the latter topic, we in the administration are happy that just last week, the Senate passed the bipartisan PACT Act, which will expand access to healthcare and disability benefits for veterans harmed by exposure to burn pits and other toxic substances, among other tools and resources. The Senate passage of the PACT Act is a great step forward, but veterans can also face other unique health challenges. Because of the stressors many encounter in the line of duty, in daily military family life, and with the big changes as they transition out of service. Unfortunately, veterans are uniquely susceptible to psychological distress and mental health challenges. Service members can return from service with traumatic brain injury, symptoms or diagnoses of post-traumatic stress disorder, suicidal thoughts or behaviors, and related conditions and comorbidities. The VA is uniquely situated to probe the science and provide treatments for these conditions in an impactful, evidence-based, and lasting way. And that's what we're going to dive deeply into today. So before we get started, I also wanted to thank all of our audience members out there for joining us, whether live or listening to the recording, and to those of you who submitted questions when you registered. Our time here is regrettably short, so we won't get to all of them, but we are hoping to collate them all at the end of this series and answer any lingering questions in a blog post. I should also mention that we may touch today on the topic of suicide. And I wanted to say now at the beginning of the conversation that if you or someone that you know is in crisis, please contact the National Suicide Prevention Lifeline at 1-800-273-TALK. That's 1-800-273-8255. You can either call or text, and for veterans in particular, you can use that same number and press 1 to be routed to the Veterans Crisis Line. You should note that on July 16th, this number will transition to a new 3-digit dialing code, 988, but will continue to be free, confidential, and always available. So without any further ado, let's get into our discussion with our guests. So Dr. Campbell, I'd like to begin with you, if that's okay. Compared to the general population, veterans tragically suffer a disproportionately higher rates of suicide. We know that this is a top clinical priority for the VA right now. Could you tell us a little bit about what we know about risk factors and why this seems to disproportionately affect veterans? Oh, I think you're on mute, Dr. Campbell.
Certainly, and thank you for the question. Suicide prevention is certainly a top clinical and research priority within VA. We are moving toward systemic transformation, both internal to the VA and external to our community resources, because we know that our veterans return to communities. So we want to make sure that we embrace the community. We have community partnerships at the level of the Governor's Challenge, Mayor's Challenge, and we have are fully staffing our VAMCs with outreach suicide prevention workers. We also have multiple evidence-based practices, evidence-based meaning driven by data and research that we implement, to include the psychotherapies, to include applications that we'll be talking about, and our award-winning veteran connecting to veterans. In terms of the higher risk to our veterans, those of us who are close to VA and to the military, while we are concerned and saddened by each suicide, the challenges that our veterans have experienced and are experiencing is not particularly surprising to us, because we understand the mission that the veterans are asked to complete and implement on behalf of our country. And we ask that our country be empathic and sympathetic to the mission of our veterans when they come home. In terms of symptoms and risk factors, we know that isolation, feeling that they do not belong, previous suicide attempts, access to lethal means, family history of suicide will place a veteran at higher risk. Also, issues regarding housing, finances, pain and oncology. These are other areas that we are expanding in terms of ID, ER risk, to make sure that we are capturing those veterans with comorbid medical issues. We also know that a large majority or more veterans who actually attempt and complete suicide have not necessarily had contact within our mental health clinics. And so we are reaching out again to the community and to the medical side of the house to ensure that we capture those veterans.
Thank you very much for that. Dr. Tenhula, I'd like to turn to you for a moment. The VA healthcare system is truly unique. It's the largest integrated healthcare system in the country, and that gives you some unique opportunities in the realm of clinical research. Could you tell us a little bit about the Million Veterans Program and efforts on precision mental health?
Sure, of course. Yeah, thanks. Thanks so much for the question, Carrie, and for hosting this event today to focus on veterans' mental health. I am really pleased to be here representing VA's Office of Research and Development and our amazing VA research community. As you may know, VA's research program covers the entire spectrum of research related to veterans' health, spanning from basic lab science to clinical research studies, as you mentioned, and specialized research on rehabilitation that's relevant to veterans, and all the way to health services research, where we look at how our healthcare system works and how we can improve the quality and delivery of care to veterans. And the Million Veteran Program, or MVP, as we call it, which you mentioned, is a fantastic example of what you were just saying, how VA research and veterans benefit from having a research program that is embedded with this large integrated healthcare system. MVP is our national research program to learn how genes and lifestyle and military exposures affect the health and wellness and illness of veterans. And with over 890,000 veterans enrolled as of last month, May of 2022, it is the largest genomic research program of its kind in the world. We are aiming to hit that million veteran mark in 2023, and look forward to that. And one example of the Office of Research and Development's precision mental health efforts is actually a direct extension of MVP. It's a program called MVP Mind, where MIND stands for Measures Investigating Neuropsychiatric Disorders. And MVP Mind will include targeted recruitment of veterans into the MVP research program with veterans with a wide range of mental health conditions. And in addition to enrolling and participating in the standard MVP study protocol, participants in the MVP Mind part of the study will complete an additional survey that will gather more detailed information on factors related to their mental health specifically. And our hope is that by doing this research, we will find out, we'll get to a better understanding of mental health conditions and potentially new biomarkers and treatments as well. And I would like to also mention another, you asked about precision mental health initiatives, and I'd like to mention another effort in that vein, which is that we recently launched as part of VA's response to the Commander John Scott Hannon Veterans Mental Health Care Improvement Act, or the Hannon Act, as we call it. One of the things that we'll be doing with this project is using pharmacogenetic testing to inform clinicians about a genetic marker related to drug metabolism. So let me say a little bit more about that. What that means is that we'll be able to help the clinicians by providing them with information about a veteran's genetics, that will be able to help the clinicians make personalized decisions about which opioid medications to prescribe for an individual veteran. And that will help, we hope, improve treatment effectiveness for those veterans, reduce the chances of adverse effects, and in turn reduce the risk of opioid use disorders among those veterans. And so again, really using very personalized approach, understanding the individual veterans, genetic variations that an individual veteran may have to help guide treatment decisions. And also, as part of this overall precision brain health initiative under the Hannon Act, we are looking at identification of and validation of additional biomarkers for brain health, and ways that we can increase our data sharing efforts related to mental health and brain health disorders. So really excited about these efforts going forward, and happy to have a chance to share a little bit about them.
It's amazing to see the realization of personalized medicine after many years of talking about it. So this is really for both of you. Over the past couple of years during the pandemic, where we have certainly seen a lot of challenges as a nation, as well as a shortage of mental health care providers, we know that a lot of Americans have turned to digital health tools or apps that are related to mental health care access. I know VA has been working on some of these types of tools. You're really on the leading edge of that digital health approach. Would either of you be able to share one or two examples of what the VA has been working on, and how do you measure how these sorts of devices or approaches are working? Dr. Campbell, maybe I'll start with you.
Sure. So we learned a lot with the pandemic, and we were able to fairly easily roll out telemental health across the country, primarily because within the VA, we don't have licensure restrictions. So as long as you're licensed in a particular state, you can practice anywhere within the country. That was extremely helpful. And then we had the technology in terms of the iPads and mobile devices. So we rolled out about 99,000 iPads to veterans, and some of those went actually into the shelters. So for our homeless veterans, we were still able to deliver telehealth services to them. And we learned that particularly for some of our younger veterans, that technology was very convenient for them. They didn't have to leave home. They didn't have to come to a VAMC and then figure out parking. And we were able to deliver care right into the privacy of their home. And they're quite satisfied. We've learned through our veteran experience data that they feel equally satisfied and qualified, and the quality of care rather with that modality is equal to face-to-face. It also decreased the risk of coming into the hospital and possibly contracting COVID. So we were able to maintain safety in many ways using those devices. We have about 16 mental health apps. VA's first ever mobile PTSD coach launched in 2011. We've had about 950,000 downloads from that. And then the COVID coach, which deals with stress and anxiety. We've had about 230,000 downloads from that. We have an app called CBTI, which is cognitive behavioral therapy for insomnia, which I've actually used and is accessible to anyone in the community. And so we have a plethora of technology and apps, evidence-based, that can be used throughout the country. And we're really proud of that work.
That's great. Dr. Tenhula, anything to add?
Yeah, Carrie, I'll just chime in and say a little bit about what we've done on the research side of things. Our Office of Research and Development has funded research to evaluate the impact of the various digital health tools and apps like the ones that Dr. Campbell just described. I'll give one example of some recent findings, which was our researchers found that the use of a web-based cognitive behavioral program called De-Stress for women veterans with post-traumatic stress disorder led to greater improvement in PTSD symptoms when compared to phone monitoring. And so when we make these apps available, we also want to do an evaluation of whether they are effective and whether they accomplish what they intend to. And we're funding currently a number of additional studies that are underway in this area using digital technology to monitor the effects of an emotion regulation skill on alcohol craving and stress. We have another project that is looking at a set of mobile health tools to see if they can promote social and community functioning and prevent suicide, specifically targeting veterans with bipolar disorder. We have researchers that are looking at a combined recovery program and home telehealth for veterans with substance use disorders. I could keep going. You can tell we have a lot of research going on in this area that I'm super excited about, but I know that we have other topics we want to cover. So happy to talk more about that anytime, but I'll stop there.
I'll just add also, we continue through mobile technology and telehealth to do our suicide screenings and our clinical screenings, like the depression screen, the anxiety screen. Those all can still be done virtually.
Right. And we are looking at the effectiveness of doing those screening from a research perspective, the effectiveness of doing those screenings remotely and doing mobile symptom tracking, et cetera. So really nice synergy, I think, between what we're doing to make clinical services and assessments available to veterans and the research that we're doing. So thanks for adding that, Dr. Campbell.
Yes, really exciting. Thank you both. It's been a tough couple of years for a lot of people, for the country as a whole. And I think we are all continuing to reel from major tragic events in the news, whether that's mass shooting or natural disasters. And I know, speaking personally, I find myself thinking sometimes about my own mental health and wondering, what is healthy mental health? What is a range of sort of expected or appropriate responses versus where's the point where I might need to ask for help? And I'm wondering if either of you have thoughts on this, particularly given the stressors that we know military members and veterans and their family members face. Is there some sort of evidence for when someone crosses the line from healthy to unhealthy in the mental health state?
So I guess I can start with that. In VA, we have what's called a whole health approach. So we are moving from a disease model and pathological model to looking at a person's wholeness from the very beginning. And so we engage the veteran at whatever point they want to be engaged. Doesn't necessarily mean they will need intensive care. Maybe they'll need a coach or a peer specialist to help them through a rough time. Or maybe they just need an app, right, to download and deal with stress. And so just teaching about the wholeness of the individual, how to monitor your own behavior and body changes. So the veteran, we understand each other from an individual perspective. In general, if you've noticed a change in your loved one, like they're isolating, you're trying to contact them and you're not getting an answer, they start talking about very negative things, or you know that they have access to weapons and a lot of them, that's probably a red flag that intervention needs to take place. And we don't always know. So we have consultation within VA through many areas, the suicide prevention piece, the PTSD piece, where you can actually call and talk to a provider, and we can walk you through whether the veteran needs to come in or maybe there's a community intervention, et cetera.
And Carrie, that's a great question, because, you know, as Dr. Campbell noticed, you know, noted, one of the things I always think about is whether someone's behavior has changed, or whether their mood seems to have changed, whether their sleep has changed, or appetite, their energy level. Those can be signals. And while we have standard diagnostic criteria for different mental health conditions that can guide clinicians and researchers in making mental health diagnoses, one of the big challenges, both clinically and in research settings, has to do with how we can assess mental health. How do we know, as you said, if someone has crossed over into an unhealthy state? And for that, we pretty much have to rely on self-report, what the person says and how they describe how they're feeling and what they're experiencing. People aren't always great at that. And to be totally, I'm not always great at it. People generally aren't really great at it. We don't have a swab that you can put up your nose like you can to test for COVID, or a cuff that you can put on like we can for measuring blood pressure. Measuring mental health is really a challenge. And we face that both, again, in the clinical setting and in the research setting. So it's a really important question, and something that we need to continue to work on.
I'll just add also that I think we, as a country, need to take a look at teaching models of developmental milestones that are normal for all of us. So we understand, like, what is a normal trust versus mistrust issue that is just a developmental milestone, or something that's more, that is requiring our attention. And there are many models out there. I mentioned the other day that I like Erickson, because as I get older, Erickson takes us through old age, right? From the beginning of life to the end of life. And so I think we can do a better job of just teaching what are the normal developmental milestones that we're all going to go through, right? That we all need to come to terms with some type of conflict that's not pathological. It's just a normal way of life and development.
That's such an important point. Yeah, I mean, and you know, so we like to say mental health is health, and we're used to tracking physical milestones to monitor our physical health. So this is you know, taking that same modality into our mental well-being. So it's a great point. You both mentioned some pretty exciting and cutting edge advances in mental health care that the VA is implementing or learning more about. When, you know, as we see these developments happen, as we learn a lot more about how the human brain works, because neuroscience is running at 1,000,000 miles an hour right now, how do we prepare the healthcare practitioners of the future, mental health care workers, providers, to think about the future of mental health based on what we're learning today? Dr. Tenhula, do you want to start?
Sure. And I'll start by saying that, again, going back to the point that you made early on in our conversation, Carrie, about VAs research or being embedded in this large integrated healthcare system gives us a huge advantage in this way, I think. Once we have scientific evidence that a treatment is effective, then VA is able to train our mental health providers on these latest treatments. And I will say, as an example of that, the VA's evidence-based psychotherapy training program, which is run out of Dr. Campbell's office, is often touted as a model for training mental health clinicians. And then from a research perspective, we can use implementation science approaches to then do research within our healthcare system on how can we help those clinicians provide the most effective treatments in terms of workflow, in terms of clinic setup? How can we train them the best? What are the best ways to train them in using these new treatments? What kind of supervision do they need in order to be effective? And so it, again, is a really nice synergy between the research that we're able to do and looking at clinical implementation. And because the VA research program is embedded in this huge healthcare system, most VA researchers are also clinicians. And so we're right there in the clinic and have unique opportunities to bring research supported treatments to veterans and to train our clinicians to do those treatments. We can try things out in different clinical settings and simultaneously do research to evaluate how well it works. So I think it's we have some really nice models for the providers that are within our healthcare system. I would say, as far as preparing the future mental health workforce in research, I'm really proud of the programs that we have in our office to support and train new researchers, young investigators. We have a strong career development award program for supporting and mentoring junior scientists. Specific to mental health, seeing the need to further develop that pipeline. We, a few years ago, established a specific track for psychiatrists to receive career development awards. And, again, that program helps us not only build the future pipeline of researchers, but also helps us attract and keep well-trained and talented clinicians to work in VA and provide direct care to veterans. And so I think, we have, again, it's that synergy that allows us to, I think, really develop a robust pipeline within the system. And I'll just mention quickly one other thing that we've just recently started is creation of a research scientist training program in conjunction with minority serving institutions. It's one of our efforts to increase the diversity of our research pipeline. And the centerpiece is a career development award mechanism, a funding mechanism to support early career scientists who are affiliated with minority serving institutions and then collaborate with their local VA medical center. So it's a program that's just getting started, but we're super excited about it and super excited about the potential of that for developing our pipeline, really both for research and clinical care.
And I'll just quickly add that we train in VA. 70% of the clinicians in this country come through VA for training through the Office of Academic Affiliations. And so we have residency programs in all areas. And then for physicians and dentists, we actually collaborate with our medical affiliations to bring those clinicians in. And the goal, of course, is to keep that wisdom and training within VA. And so that's for the professionals. And I'll just quickly add, for lay people, there's something called psychological first aid, just like CPR, so that you can get on our website and just go through. There's about 7 models, I think, modules that you can go through just to learn the basics of psychological first aid and how you can be of help to your neighbor if that should be needed.
Great, thank you. So it's a little bit of a cliche, but I became a scientist because to me, science and research has always meant hope on the horizon. And we've talked a lot about problems, and we know our nation is struggling with the mental health crisis, and veterans in particular may be affected by this. But I'd like to end on an optimistic note, and just in our last couple of minutes, ask each of you to briefly tell me, what are you most excited about on the horizon in terms of science and clinical advancement? So Wendy, you want to start?
Sure, I'll start. We're both being so polite. You know, honestly, we've touched on a couple of the things that I'm today already that I'm most excited about and optimistic about. The precision mental health efforts and ability to personalize care and to bring evidence-based care to veterans, really through some of the tools we talked about, wherever they are and whenever they need some extra support or some intervention. So I think we've touched on a couple of things. I'll say, you know, we've also invested more on the research side of late in suicide prevention, understanding risk for suicide and understanding what interventions might be effective for preventing suicide. And I think that's an area that I'm very optimistic about making headway. And we've set up some really great infrastructure within our system to support research in that area that I think really will take things forward in our understanding, and really look forward to continuing to work with our clinical partners to identify what are the next things that we need to continue working on together that are going to make a difference for veterans and their mental health. So you know, really excited about the partnership that we have with the Office of Mental Health and Suicide Prevention as well.
Yeah. And I'll just add,
Thank you.
The entire country is now talking about mental health. And our generation now, I think, is more comfortable talking about mental health, reaching out. I think we're breaking down the stigma, and people aren't as hesitant as we were, let's say, back in the day, just about discussing it. I am really pleased that at the top levels of our government, the president, the VA secretary, they have a very high level understanding of mental health, and they are talking about it. We have line item funding that Congress is supporting and the White House is supporting for us to take out to carry on these initiatives. That is all very optimistic and promising. And we really love the collaboration.
Great, thank you both. I feel like we could talk all day, but we're going to need to wrap up. Tamara, Wendy, thank you so much, both for your time, your expertise, your public service. I'm incredibly grateful. Thanks to everyone who is tuning in. I just want to note as we wrap up here that we have future events in the series planned throughout the summer, and we hope folks will continue to tune in. The next upcoming conversation is going to be on July 21st, again at 1 p.m. Eastern Time, and we're going to focus on how science has offered hope for treatment-resistant depression, and hear about the amazing story of ketamine, which is both an extraordinary story of science as well as really moving human impact. So we'll follow up by email with more information for those of you who are on the list. And please keep an eye on the OSTP website and Twitter feed for more opportunities. So thank you again. And with that, we're going to conclude our conversation. Take care.
Thank you.
Thank you.
Bye-bye.